Hello, friends from India and friends from out of the country and friends from the United Kingdom. A very good evening to all of you and good morning to countries who have been watching us out of our time zone. IAGES takes pride and privilege in hosting the IAGES Prime Time, which showcases the best of the talents across the globe on various subspecialties. IAGES strives hard for promoting the minimal invasive surgery academics on various modes, of which the IAGES Prime Time is one of the very important mode in showcasing the people who have spent their lifetime and career on gaining special experience on single zone. Today, we have our National President, Professor L.P. Thangavelu sir, amidst us to welcome all of you. Can we have the honor of listening to our President, Dr. L.P. Thangavelu sir?
Good evening, friends. I am L.P. Thangavelu, President of IAGES. Greetings from India, IAGES, and Professor Tom, Professor Jonathan, and my good friend Selva and Kanagavel. Our moderator has not joined. Kanagavel, not joined. I'm really honored and happy to be here to participate in this prime time to welcome you all for this excellent program. IAGES is, you all know, it's a very premier association in India, propagating minimal access surgery with a membership of more than 10,000 life members. And we are involving ourselves in IAGES, involving ourselves in a lot of academic activities. Our main objective is academic activity. The other, apart from academic activities, we are having a lot of social responsibilities. Also, we involve ourselves in many social activities, like during COVID time. We have set up a COVID task force, and we have helped many people, many institutions, many practitioners. Wherever help is needed, IAGES went there and helped out. And during flood times in Chennai, IAGES contributed. And not only in Chennai, many areas, we IAGES involved ourselves, all our members took active part in helping people in and around the affected areas. Our academic activities, we are conducting many CME programs, and our prestigious programs is fellowship programs. We are training young surgeons in basic laparoscopic surgery and awarding fellowships, and it's a well-structured, well-planned program, and 40 modules of lecture session, live surgery, endotrainer, so on, and almost all the eminent faculties in India are participating in all our fellowship programs and training they are enthusiastic in training the young surgeons. So, and we are awarding FIAGES fellowship programs. And in advanced surgery also, we are training people, surgeons, after basic surgery. Sir, welcome, sir. Prasanna, welcome. We are training a lot of our youngsters in young surgeons and advanced laparoscopic surgery also. The endoscopy, which has slipped out of surgeons' hands in India, that we are surgeons are taking, IAGES members are taking serious efforts in bringing back endoscopy to surgeons' hands, and we are conducting several skill courses in basic, surgeries like cholecystectomy and hernia. We are conducting several programs to give tips and how to manage the problems. how to do the surgery step by step. What are the complications? If the complications occur, what are the bailout options and how to manage the complications? All these details we are, and we have trained more than 4,000 surgeons in basic fellowship surgery, and we have trained nearly 1,200 young surgeons in advanced surgery also. Apart from that, we are encouraging a lot of research activities. We are creating several awards for research activities. For the postgraduate thesis, we have created 5 lakhs every year for 5 postgraduates to encourage them to come out with good thesis. In national congresses, we have created for best video presentation and for best paper presentation. We have created 5 lakhs each in each area, and we are giving these awards to postgraduates to encourage them in academic. And we have created traveling fellowship for 10 young surgeons, each 1 lakh. They can go and have training at any recognized center in India or abroad, or under a recognized professor. And best paper presentation in JMAS. For that also we are giving awards for 5 persons. And best research papers, we are giving awards for 5 persons, each carry 1 lakh, totally 5 lakhs. And we are having international collaboration with other organizations, ALS, DBI, and IPSIS, ELSA, and SAARC countries. And we are conducting periodic online programs, and we are inviting them as faculty to our conference, national conferences, midterm conferences, and regional conferences. Similarly, they invite us as faculty to their conferences. With these few words, I welcome you all to the National Congress, which is going to be organized in a very grand manner at Coimbatore, southern part of India, in February 9, 10, 11, 2023. With this few words, I welcome my good friend Prasanna Kumar Reddy. Thanks for your presence here, Prasanna. Thank you very much.
Thank you.
Thank you, President. Ladies and gentlemen, I have the honor of inviting and introducing the moderator for this evening, Professor P.K. Prasanna Kumar Reddy, an eminent minimally invasive surgeon and the lead surgeon and the director of minimally invasive surgery from Apollo Hospitals, Chennai. Ladies and gentlemen, I also have to have the habit of introducing a pleasant gentleman, Dr. Chalaya Selvasekar, who has been instrumental in creating this model of the program. And I also warmly welcome the trainee surgeon, Anna. We are going to have a unique experience of listening to a young surgeon about the way we are having the program and to take her comments and interact with the senior professors here. Ladies and gentlemen, we warmly welcome Professor P.K. Reddy sir to introduce the first speaker and moderate the session, please.
At the outset, I'm very much thankful to IAGES and President Dr. Professor L.P. Thangavelu and Professor Dr. Kanagavelu, who is the brainchild of this Prime video programs. And I'm thankful to both of them for inviting me to participate in this. It is a pleasure and honor for me to introduce a young surgeon like Mr. Tan Arampalam. Arampalam is I would say that when I graduated, Mr. Arampalam has joined the medical school, and he's when I went through his biodata, I was really very much impressed. Actually, he graduated from one of the most famous medical schools, St. Bart's Medical School, where I had a brief stint of privilege of working there for a short period. And having graduated from St. Bart's Medical School, and he worked in the University of London and got his MD from the University of London. And subsequently, he got his doctorate also. And one of the most interesting things what I noticed in his CV is that he's always a very, very vibrant person with not only expert skills, but also an excellent teacher, and always would like to help others to train and teach and train and do the research. These three things are very much embedded in Professor Alampalam. And Professor Alampalam is worked in Rome with a famous professor. And from there, he got his laparoscopic skills and came back, and he was appointed as the senior consultant and at the Colchester hospitals. And really, it's my privilege to introduce him to give a talk on the surgeons and their burnout in this program. Just a few words to say. Surgeons are always burnt out. If they are not burnt out, they are not happy. But what degree of burnt out they can take, and how it can be manipulated to such a way that they will help not only the patients and the society. That's one of the important things to say. And another thing which I noticed about Professor Alampalam, there is a very nice thing I call he's beating the bowel cancer. He's one of the leaders of that, and in the campaign for the beating the bowel cancer. And Professor Alampalam, it is my privilege to invite you to give a talk on the subject. Thank you.
Thank you very much, Professor Reddy and Professor Thangavelu and Dr. Kanagavale and all of the committee of IAGES. I hope I can live up to the introduction you have given me. They're very kind words, but obviously we all work as a team. So I'm going to now share my screen, and for the next 20 to 25 minutes, I will talk to you about my experience and my thoughts on burnout and performance, how we can innovate to make surgery better for our patients and ourselves. I have some disclosures. None of these relate to this talk. So disease is very old, and you know what we are able to do in terms of our technical skills can be quite limited. Having the maximum technical skills and proficiency does not necessarily lead to you being the best surgeon in the block. And why is that? Why can we not always get these technical proficiencies to translate into great outcomes, pure safety, lack of complications, and low mortality? So the journey today will be really to look at what did the old world look like before the pandemic. I think it's important to understand what burnout is. Professor Reddy talked about all surgeons are burnt out. I think that just really reflects that we're ordinary people doing extraordinary jobs. We are ordinary people doing extraordinary jobs. And actually, if we don't have some sense of a feel for how we're performing, then we don't do ourselves or our patients any justice. I'm going to touch on the team and also look at system thinking. So this is a wide topic about how we get our best outcomes. But what I'm going to focus on is performance and how you bring your best self to work, because there are going to be some excellent talks on technical matters. And what I'd like to do is give you a flavor of how you can translate that into excellence in the real world. So we'll look at the evolution of the evidence, the reversibility and awareness of burnout, where to target interventions, looking at the concept of psychological safety, and also the impact of surgical teams and system thinking. So what are the problems? Well, the problems are that there are high rates of complication, there's relentless economic and media pressure on our outcomes, there's a focus on safety, quality, and transparency that we sometimes feel gets in the way of us delivering our training, there's regulation, there are high rates of burnout and depression and early retirement. We're particularly seeing this after the pandemic. And you can read the whole list that I've got on the screen. This makes it very difficult for us to conduct our normal day-to-day work and to deliver the service to our patients. And really the background is that there has been a global financial meltdown. We have the financial crisis of 2008, and we haven't really recovered. And there's constant political intervention in healthcare, varying from the regulation of the private sector to the expansion of public health systems, which are very costly. And of course, all the time we have aging and larger populations. We don't quite understand data and technology. If you look at the digital health and digital hygiene of the average doctor, they don't really understand those concepts of cybersecurity. And all the time our workforce is diminishing, and our planetary health and human health are so tightly connected. We have to understand how we are going to be sustainable as we go forward. And I think that sustainability is about our workforce, our surgeons. So there are several factors that come to mind. There is the efficiency targets, and there are outcome measures. And increasingly, we will be measured by our patient-reported outcomes as well as our clinician-reported outcomes. But we must remember that we are the guardians of quality. So when we have politically driven efficiency targets, regulation, and cost control, we must remember that we're primarily here to serve our patients. And the pandemic has changed everything. Surgeons were not the primary important clinician. Normally, if there's an earthquake or a disaster, a bomb, surgeons are essential. But we weren't the essential part of the medical workforce. We were redeployed. It caused anxiety. We had significant disruption to our workload. And what did that result in? That resulted in a huge backlog of surgery, millions of operations not being conducted, and millions of operations for our trainees not to be part of. So training is in crisis. And all the time we have had moral injuries where we've witnessed or taken part in things that transgress our normal moral compass. So I've mentioned this already, but this is a real problem, the aging population, the silver tsunami, and of course we have the problem of diabetes, whether it's endocrine issues, whether it's cancer, we have an impact that we're going to see. And all the time, this is impacting on patient safety. So 14 out of every 100 patients are affected by a hospital-acquired infection. 1 in 10 patients are harmed in hospital. The statistics are staggering, and we can do better. It's not about just technical proficiency. We have to have the whole package, because we know that 15% of hospital costs are due to patient harm caused by adverse events. So we can actually be part of a virtuous circle to try and make this situation better, and it is our responsibility to do so. And I've put some slides showing that, you know, even if you think you're the best surgeon in the world, we have to have some vulnerability and acceptance that our services do have complications, do have increased rates of avoidable complications and deaths. And Atul Gawande was very prescient when he actually said surgery itself is a disease. This is a very good paper looking at global health. So we have a problem. What are the root causes of these problems? And they seem to be all centered around human factors. So these are the factors that make us not machines, not entirely predictable beings, failures of leadership and failures of communication. And so maintaining surgeon wellness, so the sustainability of the surgeon, is really important. And I'd like to just demonstrate this by showing you the 4 real waves of the pandemic. The first wave that we witnessed was the health crisis. That was back in March 2020, when we had a pathogen that we really did not understand, and there were people dying inexplicably. And although that rate may be 0.5 to 1%, you know, it was huge, and we were worried about our health services being overwhelmed. We then had the second wave, which was the real impact on our resources and the restriction on urgent care. And that caused us problems over the course of 2021, when we had subsequent waves of different types of COVID. And then the third wave is what we are starting to have to deal with now. We're dealing with supply chain issues. We're dealing with the backlog of surgery that has to be tackled. And of course, we're all seeing diseases, whether we're cancer surgeons, whether we're obesity surgeons, we are seeing people at later stages of disease, which is altogether different in the way we can approach them. But all the while, there's been a fourth wave of psychic trauma to our medical workforce, our clinicians and our nurses. There's been a huge amount of burnout, there's economic injury and mental illness that we as doctors aren't the best at acknowledging, and we as surgeons are probably the poorest. So I'm going to just talk about burnout, because this is a real issue. It doesn't matter whether you're in India, whether you're in the US, whether you're in the United Kingdom or Europe. This is a real phenomenon characterized by depersonalization, emotional exhaustion, and a sense of reduced personal accomplishment. And there are personal and professional sequelae. It affects relationships. There are financial issues. You may end up with substance abuse. The rate of alcohol consumption over the pandemic and the general population has increased, and this has been reflected in our medical workforce as well. And of course, the rate of suicide is enormous. If you are reported to your regulatory body, for example, in the UK, it's the GMC, the General Medical Council, the rate of suicide for those doctors is enormous. But there's a professional problem, disengagement, problems with performance, high staff turnover, and perhaps patient safety incidents. But we can talk about that because perhaps people who are burnt out may be more likely to report patient safety incidents. And Schanafelt wrote a very good summary of this. You know, 54% of doctors are emotionally exhausted. You know, what are doctors? Patients come to see us because they're in pain or have fear. And when they see us, they transfer that to us. We carry that around in our hearts, in our heads constantly. And as a surgeon, you not only carry that, but you also have this terrifying trust that is given to us to perform surgical operations, to actually incise into a patient. And that causes a lot of stress and anguish. 40% of the NHS consultants are burnt out, and in surgeons, the figure may be 40 to 75%. 27.8% of surgeons score very highly in the depersonalization at work. That's second only to pathology and microbiology. And many surveys show that burnt out doctor is twice as likely to be involved in a patient safety incidents. And my group published on factors associated with burnout, and we found that there were some personal issues, family, income, lack of extracurricular activities. There was some psychological factors in the doctor themselves. Did they have the emotional grit? It's very interesting just hearing Professor Reddy's introduction. Of course, we need to be at the edge. We're the sharp end of the spear, but we also need to protect ourselves. So personality-wise, we need that grit. And of course, there's the work setting, academic versus service hospitals, how error is dealt with. what the workload is for surgeons. If it's more than 60 hours of work a week continuously, those are bullets that are being fired every day. And then we have to look at the work environment, job satisfaction, aggressive patients, lack of administrative support, lack of autonomy when we're working, and lack of mentoring. There's several studies showing that if you have a surgeon, if you have a clinician, and you actually want them to do stuff, the way you should tailor their workload is actually to look at giving them 20% of the time where they do something that they feel is meaningful, because meaningful work is why we all get up in the morning. And the other 80%, a clinician will do whatever you ask of them, but it's important to give them that time to be autonomous. And we know that there are problems because there's increased intensity and complexity of workload, organizational antipathy, problems with interpersonal relationships. We all know that when we go into hospital, there's a lot of rivalry. There can be problems when there's private practice involved. And of course, people have problems with their personal life. And of course, there are several myths in how you deal with this. There's the perfection myth that if people try hard enough, they'll not make any errors. And that's absolute nonsense, we know. There's the punishment myth. If we punish people when they make errors, they will make fewer errors. And we know that that isn't true either. And I love this quote from René Lariche in the beginning of Henry Marsh's book, Do No Harm. Every surgeon carries within himself or herself a small cemetery where from time to time he or she goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures. And that's what many of us carry around with us all the time. So surgeons are vulnerable because of their commitment and self-sacrifice and perfectionism. The other groups that are high risk are GPs, psychiatrists, but also we must look after our trainees. We must spend time. And recent surveys have shown that speciality-wise, the emergency services, urology, general surgery, they're all very high in the burnout index. So there was a study looking at vascular surgical trainees. What were the factors that affected them? It was depression, stress, the fact that there was no formal mentoring, a violation of the 80-hour work week, no organized social program, and low levels of social support. These are all problems. And how do we spot the burnt out surgeon? We can spot them because they're emotionally drained, fatigued and frustrated, feeling unable to accomplish much, not enjoying their work with patients. All of these things are important to acknowledge. So what should we do? Well, the immediate thing is to stop, seek professional help, speak to your colleagues and formulate a plan. It is really, really, really important. There are several resources in our country, such as the local signposting, NHS practitioner help. There's a doctor support network, and the Royal Colleges are very good now at acknowledging that this is a real problem. I think it's important that the principles that we follow are system, organization, and individual. And I really like to stress when we talk about burnout, this is not the fault of the individual. This is more often a system-wide problem that we ought to be addressing. So we can undo the damage. There are very, very basic principles, and that is all about empowerment and looking at how organizations deal with these problems and understanding that these problems start at medical school, because we accept in medical school the highest performers of our school leavers, but we then put them into a culture where there's excessive management and focus on budget with complex financial incentives. We really need to focus on quality, protect our civility, and reject greed. That's what will make us strong. And this brings me to the concept of psychological safety and empowerment. So there's been a lot written about this, and we are really starting to understand that having psychological safety in the environment and delivery of our medical practice is really important. And it can be likened to a very, very fragile vase, which we put on a table. And the table represents behaviors. These are kindness, empathy, civility, and assertiveness. They're really, really important things. But the table has to be supported by attitudes. And those attitudes are respect, humility, curiosity, and trust. And I would say to you, if you stop and think about your current workplace, do these attitudes and behaviors, are they pervasive and part of the culture? We know that there are many high reliability organizations that we could learn about in terms of changing organizational cultures, looking at outcomes, looking at the process of optimization and support. But we know that no system is foolproof for a sufficiently inventive fool. And the team is very important. And this is where the human factors come in. We have the vulnerable individual. So we need to learn team skills and team resource management. In the airline industry, this is called crew resource management. So if you all stop now and think about a team that you've been working in, what makes a good team? What were the enablers? What were the inhibitory factors? What were the behaviors that characterize both of these? So we can talk about enabling respect, autonomy, having plans, fairness, clear roles. But the inhibitory factors we see in our workplaces every single day: the domineering character, bullying, fear, being unkind, the mood hoover who sucks up the joy of being at work, chaos in terms of planning. So it's really important. And I also think we need to think about what a team is. And I would say a good definition, sorry, we'll go backwards, is a group of people working cooperatively towards a shared goal. How many of us reiterate that? And there are characteristics and team skills that NASA and the University of Texas studied. These are briefing, communication and decision-making, team self-feedback, inquiry and advocacy, leadership and followership, which is really important, interpersonal relationships and group climate, preparation and planning, workload and distractions. Those are all 8 key factors that the University of Texas with NASA found. But there's one that is the gatekeeper to all the others. Have a think what you think it is. And I would say to you, it's interpersonal relationships and group climate. So the key message is high-performing teams allow the surgeon to deliver their full potential. So there's an employer's role in this. Doing Schwartz rounds is important. I'm not going to spend time on this. We know that resilience is important, but a surgeon can't be told to just get resilient. There has to be an environment that helps this grow. I just want to finish up by just talking about the story of Charles Plumb. He was a fighter pilot for the US Navy. He flew from the US Kitty Hawk, and he was shot down over Korea. And when he was shot down, he was put in a prison for 6 years, tortured. Eventually he got out, and he was on the speaker circuit in the United States. And in the US, he was sitting at a dinner table with his wife many years afterwards. And the person at the next table, this is an apocryphal story, said, you're Charles Plumb, aren't you? And he was really surprised, taken aback. He said, how does this man know me? And he said, how do you know me? And he said, well, you flew off the USS Kitty Hawk. You were shot down and your life was saved. I was the guy who packed your parachute. So we need to know who around us is there to protect us. And I would say to you, in terms of bringing your best self to work, your 4 parachutes are your physical wellness, your mental wellness, your emotional wellness, and your spiritual wellness. Your spiritual wellness is why you get up in the morning to do such a demanding job and enjoy it. So it's all about personal recognition and self-care and awareness, that psychological awareness, making sure you stay healthy so you bring your best self to work. And I'm not going to go into detail. We can discuss this if you wish. But basically, in terms of burnout, we know that if you're going to deliver great HIPEC service, great colorectal cancer service, great bariatric service, you have to have a well surgeon. You have to have somebody who understands the tenets of leadership, and you have to have great role models. And that has to be sustained over a 30-year career. So the evidence base for burnout is growing. We know it's reversible. We're building awareness. We know where to target interventions, and we are finally understanding what psychological safety is. We know that the system is very important in all of this, and we can talk all day about that system, but we also know that the team is very important. So thank you very much for your time. I will just leave you with the thought that it's okay to be not okay.
Professor Tan, wonderfully put it, and really enjoyed the talk. And what is important message you have given is exactly what every surgeon faces. And as you mentioned very clearly, there are so many factors around the surgeons, but one of the important things you stressed on is interpersonal relationships, and then also leadership skills, and then forming a team. These are some of the important things. And other things, you beautifully showed the 4 legs of a table, that each one is important. If you miss one, the table will fall and the glass vase will break. So I really appreciate and excellent talk. I thank you very much. Very nice of you.
Thank you for the honor. It's really really good, and I'm so glad that Liana has joined us, because this is something that we old guys and ladies need to realize, that there is a whole train of amazingly talented people coming up behind us, and we need to really nurture them and ensure that they grow in the right way.
So very true, very true.
I just also wanted to ask a question in this topic. I think there has been a lot of discussion lately about the factors that affect burnout, and you talked a lot about leadership and resilience and teamwork. But what do you think is what stops people from essentially stop getting burned out? Because it seems that we are aware that it is happening, but what do you think stops us from essentially stopping it eventually?
I think it's really important that one understands that we are biological beings, that we're meant to work at a level of stress. That's what our physiology has designed. It's when that stress is not acknowledged and controlled, and when we don't have a decent output for it. So when you say how to prevent burnout, I love my work. Professor Reddy said, surgeons love being busy. There are 3 things you need to have a happy surgeon. You need a nice place for them to live. They need to be well remunerated, but most important, they want volume. So sometimes we're our own worst enemy. So in answer to your question, I think it's looking at those 4 factors. Being physically fit and healthy is really important. And giving yourself time. 69% of surgeons operate in pain. And don't be fooled by robotics, because the pain will just transfer to the small muscles of your hand and wrist and neck, rather than your back and shoulders. So pain is being physically fit is important. We need to be mentally fit. So that's your cognitive processes. Are you thinking straight? Decisions are more important than incisions. And then you need to be emotionally on the right playing field. And to be emotionally on the right playing field, that's your social support. Who are your loved ones? Who are your friends? Who's looking after you? And then your spiritual health is really important. Why do you get up to go to work? Are you still curious to help people? So if you're checking in with yourself on those 4 fronts and you're getting support, then I think the likelihood of burnout is much less. We work in very stressful situations and we get through. So I'm not one of those people saying we mustn't do these things. We've got a job of work and a vocation that we have to deliver. We have to find a way of doing that. And I think one of the ways is to acknowledge that we have to address certain issues to make ourselves turn up to work in the best possible shape. And by the way, the minimum level that I'm assuming is that you have the knowledge. So the things that Jonathan's going to talk about, the things that are part of this amazing series, is a given. So we are diligent, conscientious learners, but we have to do the other bits as well.
So Leona's question is a very interesting question. See, if you analyze it, every surgeon has got a degree of stress, and it is not comparable to each other. So what I feel is, with all my experience, you should not exceed that degree. If you exceed that degree, as you mentioned quite clearly, the burnout starts. So to keep it under control, that's where the surgeon must realize when to stop and how to stop, how to ask for help. That's the way we have to learn from that. Thank you.
Thank you.
Thank you very much.
Professor Tan, we've been enjoying your talk much, and a lot of other facts have come in, and you have given serious thoughts about even a micro issue which we have been facing, or we have been accepting as a standard of care in our practice. I have a quick question. Many systems, the Australian systems, the Swedish systems, have someone like a mentor at every level. Even the consultants have their mentor to share if something is not okay with them, or if they feel. Many times the confidentiality is almost 100%, because it is like open sharing. Yes, I am not able to accept this as a problem, or I am not able to accept this happening before my eyes. But many times we keep quiet for various reasons, for administrative reasons or academic reasons. So how is the NHS taking this issue up? Like, do we have a hierarchical reporting system, or do we have a hierarchical remedial system? And what is the role of, or how NHS, or how serious is NHS on this issue?
So it's a very good question. My answer will be take a long time to give you, but in short, I think the NHS is trying but doing very poorly. I think there are various initiatives at college levels and association levels to try and start mentoring programs and coaching programs. But you know, if you take a snapshot of trainees, we're in utter crisis, and they are not getting the support that they need. And they don't need lots of operations. What they need is that Saturday morning ward round when you went round with your senior consultant and they told you the things that you don't hear or you don't read in the books, how to sustain your practice, how to deal with the difficult patient, how to deal with the complication that really is dreadful, because when we do things that are wrong, that go wrong, that they affect us. You know, there's always a second victim. So coaching and mentorship is very important. And many people say that this happens, you know, that they're mentored to X, Y, and Z. But mentorship requires skill. It needs to be structured. And organizations like IAGES are perfectly placed to start this sort of program. I personally have a coach who I talk to every month about how I'm performing. I talk about complications and look at where I'm going. And of course, all of us as surgeons have three phases to our career: the climbing the mountain, the cruising, and then at some point we have to stop being surgeons. I think, you know, that stage up to retirement is very important, but all the while we're role models for our juniors. So Liana may be able to add to the answer to that question, but I don't think it's done very well. And the NHS is losing people because it's not using the knowledge from these very, very, very experienced people who are fed up or unhappy with the way they're being treated. And you know, it doesn't have to be like that. The NHS actually has lots of very good things structurally that it could put out. But I have to say the colleges are trying really hard, as are the associations, as are trainee groups, because they've realized that if it's not coming from above, they've got to build it themselves. And sometimes building new structures is a good way of moving forward.
Thank you very much. That sounds a lot of efforts are happening, and I'm happy you have a good coach. Like many times when we have bad results, when we are uncertain about, especially the re-entries, short early re-entries, not happens very often, but then those are the gray areas where we cannot look upon guidelines or when we cannot look upon our own impulsive decisions also. So those are the areas which we still feel sort of little uncertain, and as you grow more senior, you end up delaying the decision. That's my personal feel, because you know that by doing, if you're not positive about getting a result, then you end up delaying. But it's very nice to have a right coach, who always is the fallback option when in difficult situation. I only trust this type of fallback requirement is much less in our career, but it's always nice to hear that. I'm sure NHS is doing a great job, and I'm sure under the leadership of our president, IAGES also will have initiatives. Let us try and do a collaborative model. Let us understand how the NHS does it, and I'm sure IAGES can have an initiative on that in the near future. Thank you very much.
Thank you.
Ready, sir? President, sir, can we move on to the next talk?
Please.
Can I have the honor of inviting Professor Jonathan Weil? Can we have your presentation, sir?
Certainly, I'll share my screen now.
Just
Can
to
you
give
see
a
that?
bit of an introduction, Professor Wild is a consultant colorectal surgeon based in the Christie in Manchester. He trained in Sheffield, and he has done a fellowship looking at the peritoneal surgery in Ireland, and he's also done advanced colorectal surgery fellowship with Professor Pete Sagar in Leeds. So he's an experienced surgeon, and he's interested in surgical education. Thank you very much, Jonathan, for giving a presentation today.
Perfect introduction, Selva. Thank you very much.
Thanks for the introduction, Sekar, and good evening, everybody. Many thanks to the Indian Association of Gastrointestinal and Endosurgeons for the invitation and the privilege of speaking to you this evening. I don't have any conflicts of interest. So I'm, as Sekar says, I'm a surgeon at the Christie Hospital in Manchester, which is the largest single-site comprehensive cancer centre in Europe. It's the first of its kind in the UK. And at the Christie, we treat over 60,000 oncology patients per year. Around about, that covers the population, the 3.5 million population of Greater Manchester, but about a quarter of our patients come from the rest of the UK and further afield. In terms of the Colorectal and Peritoneal Oncology Centre, or CPOC, we've been a UK nationally commissioned centre for cytoreductive surgery and HIPEC since 2002, so we're approaching our 20-year anniversary. And over that 20 years, we've performed over 1,500 cytoreductive surgery and HIPEC procedures. Today, around over 100 of those performed minimally invasively. We perform about 200 cytoreductive procedures with HIPEC a year. We also do other things. So we're a group of 9 colorectal surgeons. We're also a referral centre regionally for pelvic exenturative surgery. We're a specialist regional sarcoma service. We're also a European Centre of Excellence for neuroendocrine tumours, and we have the largest anal cancer MDT in Europe. So in terms of context to this talk, which is about laparoscopic or minimally invasive cytoreductive surgery and HIPEC, for context, cytoreductive surgery and HIPEC is an effective treatment for a variety of peritoneal surface malignancies, including peritoneal metastases arising from the appendix, the low-grade mucinous appendiceal neoplasms, the LAMs, which give rise to pseudomyxoma peritoneal, or PMP, and also the more invasive appendix pathologies, the appendix adenocarcinoma and goblet cell adenocarcinoma of the appendix. But it's also cytoreductive surgery and HIPEC is also indicated for peritoneal metastases arising from colorectal, ovarian, primaries, gastric primaries, also for malignant mesothelioma and benign multicystic mesothelioma. So again, some more context in terms of what is cytoreductive surgery and HIPEC. Well, there's two components. There's the cytoreductive surgery, which is removal of all the macroscopic peritoneal disease. And then that's followed by combining the cytoreductive surgery with HIPEC, or hyperthermic intraperitoneal chemotherapy, which targets any potential residual microscopic disease. In terms of how we quantify peritoneal disease burden and distribution, we have Paul Sugar-Baker's well-established peritoneal carcinomatosis index, or PCI, where we divide the abdominal pelvic regions into 13, giving each a score 0 to 3, depending on the size of the largest lesion. So the higher the PCI, the worse prognosis. And then we have the standardized assessment of completeness of cytoreduction, the completeness of cytoreduction score, or CC score, where all disease is removed, gives a CC score of 0. If there's peritoneal implants remaining that are unable to be resected, there's a diameter of 2.5 millimeters, then or less, that gives us a score of CC1. If there's any residual disease greater than a quarter of a centimeter, then it's a score of 2 or 3. A score of 0 or 1 is defined as a adequate or complete cytoreduction. A 1 because the HIPEC, when combined with HIPEC, the HIPEC can penetrate tissues up to 4 millimeters. So if there's a 2.5 millimeter nodule, then we have to assume that HIPEC treats that successfully, hence a complete cytoreduction. So in terms of, this is open cytoreductive surgery survival. This is our data at the Christie. You'll see that the blue lines in these survival curves are for patients who've had a complete cytoreduction, so a CC0 or 1. The red line is unfortunately patients that were unable to achieve a complete cytoreduction, so a CC2 or 3. And you'll notice a clear survival benefit, patients in whom you achieve a complete cytoreduction. So if we're looking at this survival curve, which looks at the patient group with PMP, or low-grade appendiceal neoplasms, the overall survival is over 95% at 5 years. Onto the more invasive appendix pathologies, then still when patients have a complete cytoreduction, we get good outcomes with 70% alive at 5 years. The survival isn't as good for colorectal peritoneal metastases due to the nature of the beast, but in those patients who have a complete cytoreduction, about 40% are alive at 5 years. Median survival in this group of patients is around 44 months, which is much more effective than the alternative, which is systemic cancer therapy. However, open cytoreductive surgery and HIPEC is associated with significant risk of major morbidity, long length of stay. Contemporary reviews of morbidity and mortality following open cytoreductive surgery and HIPEC demonstrate a significant risk of high-grade morbidity of between 10 to 34%, and 30-day mortality of between 0.8 to 4%. So that's more contemporary data published. Going back a decade or two before, then the rates of high-grade morbidity and mortality were much greater, but things have certainly improved over the last decade. And that morbidity and mortality compares well to other major intradermal resections. But our data at the Christie again compares extremely well with the published data. But when it comes to open cytoreductive surgery, it's the maximally invasive approach. It's the long midline incision from the xiphisternum right the way down to the pubic bone, which certainly is the major contributor to morbidity in these patients. So, can the benefits of laparoscopy be transferred to cytoreductive surgery and HIPEC, and vice versa? Are the oncological benefits that I've showed in the survival curves are they achievable with a laparoscopic approach? Well, in terms of laparoscopic cytoreductive surgery HIPEC, in terms of any both open approach as well, careful patient selection is critical, and certainly more so with if you're considering a minimally invasive approach. You see this CT scan of a patient with high volume PMP, the calcified appendix tumor with large volume of mucinous ascites, and this patient with a locally advanced colorectal adenocarcinoma with peritoneal disease. You see a colonic stent there. This approach isn't something you could attempt with the laparoscope. It needs maximally invasive surgery. Whereas in other this other patient scans below, where these patients with localized small volume, often unicompartment disease, localized stable disease, which lesions are accessible with a laparoscope, then a minimally invasive approach could be considered. And certainly there's great potential benefits for patients, potentially to be achieved with a minimally invasive approach. It's obviously less invasive, reduced length of stay, as we know, early return to bowel function, reduced time to recover, and earlier to resume normal activities, and obviously a better cosmetic outcome. But there are major concerns over laparoscopic approach. Through the laparoscope, you need a really for cytoreductive surgery, initially you need a really careful and thorough assessment of the peritoneal cavity. And through the laparoscope, as we know, it's difficult to visualize those hard to reach places, high up below the diaphragmatic surfaces, deep down in the pelvis, lesser sac, especially in patients with a high body mass index or patients that had previous surgery with adhesions. When performing laparoscopic cytoreductive surgery, you're required to change the patient on the operating table in multiple positions. You need to be able to operate in multi-abdominal compartments. You need at least 2 screens in your theatres, at least 2, and certainly a fully integrated laparoscopic theatre is beneficial. A 30-degree scope is required, as is a HIPEC perfusion machine that is capable of delivering HIPEC with a closed abdominal technique. And above all else, a lot of patience is required for this type of surgery. But certainly loss of tactile feedback is an issue. You lose the ability to detect potential very occult small peritoneal implants, especially those along the mesenteric border of the small bowel that you often find at cytoreductive surgery by running the small bowel. You don't see it, but you feel it. And the concern is with the minimally invasive approach, then these lesions can be missed. So you're heavily reliant on good quality cross-sectional imaging. And even in high quality CT scans, often it will miss small nodules less than 0.5 centimeters. So there is an overall concern, and it's a similar concern when it comes to resections for locally advanced GI cancers, that the minimally invasive approach could potentially compromise oncological outcomes. In terms of the evidence for laparoscopic cytoreductive surgery in HIPEC, the first case series was published by an American group back in 2011, and over the last decade, particularly in Europe and in Spain, there's been a lot of enthusiasm, especially in a group in Cordoba in Spain, about performing laparoscopic cytoreductive surgery in HIPEC even for more invasive malignancies with ovarian and colorectal peritoneal metastases, as well as performing for benign multicystic mesothelioma. There's a single case report from Saudi Arabia describing safety and feasibility of performing single incision laparoscopic surgery for cytoreductive surgery in HIPEC. And a case report for PMP and a small case series for ovarian peritoneal metastases where the Da Vinci Xi is used for a robotic assisted cytoreductive surgery in HIPEC. In terms of better quality evidence, published last year is the Peritoneal Surface Oncology Group International, or SOGI, and their International Registry of Laparoscopic Cytoreductive Surgery in HIPEC. And this has allowed for cumulative experience and assessment of what is a specialized treatment performed in specialist centres for rare tumour types, and it's extremely difficult to get any quality data from single centre retrospective cohort studies. So this study was contributed from 10 high volume specialist centres, so they could perform a minimum of 50 cytoreductive surgery and HIPEC procedures a year. Overall, there was 200 patients registered. In terms of the analysis of the data, 57 patients were excluded who've had what we call risk-reducing laparoscopic cytoreductive surgery and HIPEC. So they're patients with a PCI score of 0. And so in total, 143 patients were included in the analysis. And you can see this is a different selected patient group. A younger patient, mean age of 53, eldest patient was 61. They have a normal BMI, with a BMI of median BMI of 25. Highest BMI performed was 28, and which is very unusual for if you're operating in the UK, I can tell you. But 90% of the surgery, 90% of the patients had only minimal surgery previously, so that may be in a laparoscopy or biopsy, appendectomy, or a single quadrant resection. And around 75% of patients in this group had less invasive and more indolent pathologies, so the PMP, multicystic benign mesothelioma pathologies, whereas 25% of patients had underlying diagnosis of more invasive malignancies. And 90% of patients, the surgery was performed for primary disease, so 10% of procedures were done for recurrent disease. And this is the main take-home message for minimally invasive approach, is that in this group of patients had a very low single-figure PCI of 3, so the range of 3, maximum PCI in this group of patients was 5. And these are the patients to target potentially with the minimally invasive approach. Around about a third of patients did, however, have a resection, either small bowel or colorectal or splenectomy. And in total, overall, 100% of patients got a complete cytoreduction, with 97% a CC0. And in this group of patients, the time of surgery was all things considered was pretty good, with mean time of surgery of 300 minutes with minimum blood loss, as expected. And as expected, the length of day in these patients was short. Median length of stay 6 days, compares much better to the open group of patients, with low morbidity and low mortality. So how does laparoscopic cytoreductive surgery and HIPEC compare to the open approach? Well, colleagues at the Christie published a study where we compared laparoscopic risk-reducing cytoreductive surgery and HIPEC with versus open this is for low-grade penicillin mucin neoplasms that are perforated. So the two groups were well matched. Main difference was certainly operative time was significantly longer than the laparoscopic group, roughly an average an hour and a half longer. The PCI score, there was no difference between the groups and no difference between blood transfusion rates. A significant difference, however, was with length of stay, both in terms of critical care admission, where almost 100% of patients in the open group go to critical care unit post-operatively, whereas 50% of the laparoscopic group did. And the median length of stay was 6 in the laparoscopic group, and compared to 10 in the open group. And there was no difference between morbidity and mortality. So I'll move on now to a video case, and this is a case of where we performed a laparoscopic risk-reducing cytoreductive surgery and HIPEC in a 66-year-old male who previously had undergone a laparoscopic appendectomy for an incidental mucociliary appendix. On histology, it was found to be perforated with acellular mucin on the serosal surface of the appendix, or LAM2. and the post-operative post-appendicectomy CT scan 12 weeks later showed only a minimal trace of fluid in the right iliac fossa. So this was essentially a normal CT scan. The patient was referred to our specialist centre, had a specialist pathology review to confirm the diagnosis, a review in our peritoneal tumour service MDT, where we offer the patient either surveillance with 6-month CT scan with scans then to annually, then 18 monthly up to 8 years, and then or the option of a laparoscopic risk reducing surgery, which the patient decided to go forward with. So hopefully this video will work. So in terms of how to perform laparoscopic cytoreductive surgery, in terms of port placements and pneumoperitoneum, that's created in a standard fashion by insert 5 ports in the horizontal plane just above the umbilicus usually. And after the cytoreductive surgery is completed, the specimen is extracted, I use a 12mm trocars to insert 4 ports to deliver the HIPEC in the into the 4 ports onto the right hand side to deliver the HIPEC. So the start of the procedure requires a very careful laparoscopic assessment, thorough assessment of laparoscopic cavity. And you can see here there's I've just paused the video. You can see there's unexpectedly we found several mucinous deposits over the right liver surface, despite there being a normal CT scan. Up in the left upper quadrant, that was fine. There was no evidence of any disease there. You can see down in the pelvis, there's some ascites, but also a thin film of mucin in the pelvic, covering the pelvic peritoneum. So onto the right of that fossa, and we divide the adhesions in order to assess the appendix stump for any potential residual disease, and also to open up the planes here to expose the HIPEC agent to this area. This patient had an R0 appendicectomy, so there was no need to do a completion cecal pole excision. And as part of the thorough assessment, requires a full run through of the small bowel, examining, you see the DJ Fletcher was examined, then right the way down to the TI, looking at the serosal and mesenteric surfaces. And back down to the pelvis, this technique, we're using a tonsil swab in Johan to rub and wipe all the mucin from the peritoneal surface. So this case doesn't need a peritonectomy. It's just surface disease. It's easily removable, as same techniques used here in the right upper quadrant of the diaphragmatic surface. But looking further, there's concern here that there was further mucin around the back of the right lobe of the liver. You can see there's some disease on the liver surface there as well. So the additional 5mm port was inserted, and that enabled using a hook diathermy to divide these adhesions around the right lobe of the liver posteriorly in order to access that area, ensure that all the residual disease is being removed. And then using the diathermy to ablate the liver surface disease. So moving on to the cholecystectomy, and the main learning point, different technique here is the use of hemolox rather than Liger clips. There's less chance of them being dislodged during the HIPEC. And now the falciform ligaments and the ligamentum teres are excised here using the good tension with the left hand and using the hook to zip down the liver surface to reset the falciform ligament here. So moving on to the greater omentectomy, and here you need a good assistant that you need to make good use of to display the greater omentum nicely as a sheet, and then begun the careful dissection, combination of sharp and blunt dissection to carefully dissect the greater omentum off the mesocolon, obviously taking especially care and attention to avoid damage to the middle colic vessels. Using a Thunderbeat device here. You can see now the lesser sac is opened, the posterior surface of the stomach and pancreas are displayed. And we continue dissection then up towards the left upper quadrant and the spleen. And actually, as you'll see, coming around splenic flexure, I think you get better views here through the laparoscope than you do at open surgery. And you usually stop there in left upper quadrant and turn my attention back towards the greater curve of the stomach to divide the gastroepiploic vessels, an arcade here. And then dividing the main gastroepiploic trunk with the Thunderbeat device around about the level of pylorus or D1. So again, there's back up to the left upper quadrant, there's one remaining tongue of omentum up towards the spleen. As this is risk reducing surgery, we're going to preserve the spleen and then decide a level to transect safely to avoid any iatrogenic splenic injury and divide the final part of omentum here, just inferior to the splenic hilum. So the final part of the dissection is a vagal nerve sparing lesser omentectomy. The specimens are all then placed in a Burt bag and extracted by extending the umbilical port site incision and then performing an umbilectomy as we do as standard. The ports are then converted to a 12-month trocar to insert the 4 HIPEC perfusion drains, and then we begin the HIPEC with the close technique, and here using mitomycin C with 3 pulses over 90 minutes. So in terms of this is my final slide. So overall, I recommend laparoscopic cytoreductive surgery and HIPEC but for highly selected patients with low-grade appendiceal mucinous neoplasms with a normal post-operative post-appendicectomy CT scan that does not demonstrate any extensive peritoneal disease, because that's PMP and that requires an open cytoreduction HIPEC. So for patients with low PCIs and the risk-reducing procedures, for invasive peritoneal surface malignancies, there's a word of caution. There may be a role for minimally invasive surgery here, but cytoreductive surgery HIPEC for highly selected patients with low PCI potentially, but given the current limitations with cross-sectional imaging and with laparoscopic imaging, certainly the standard of care for invasive malignancies, the adenocarcinomas, gastric, ovarian, colorectal, goblet cell cancer of the appendix, as well as malignant mesothelioma, an open approach is still recommended. So thank you for listening, and does anyone have any questions?
Okay, sir. Professor Weil, it's been a lot of clarity, and the videos which show was very clearly emulating the steps of the procedure. I would like to ask one quick question.
Sure.
You very categorically said how to choose the patients for the surgery. There have been some studies which mention we can do a staged peritoneal surgeries. Say, for instance, you remove, say, a certain amount of 60%, 70%, and then go for a second procedure after a few weeks. Do you still have, or do you believe this stage procedure, or you always believe it should happen in one go?
No, definitely. So we're not talking about a laparoscopic or minimally invasive approach for these type of patients. This is for, you're talking about open cytoreductive surgery, HIPEC, as a staged approach, and definitely that's a for certain patients that's the right way forward. I think definitely so, and in terms of the benefits are often that's used for high volume PMP. So in a patient where there may be, because of the PMP process, they're cachexic, malnourished, and they need to get out of trouble. So putting them through a one operation with a complete cytoreductive surgery, HIPEC, 14 hours of operating, multiple visceral resection in a patient that's won't be able to tolerate that. So they're the type of patients that benefit from a staged approach with an upfront we call them debulking laparotomies, so a diagnostic debulking laparotomy. So the advantage of that is that you drain all the mucin, you remove the primary appendix tumor, ovaries in women, and a limited or infracolic greater lumpectomy, and not doing too much in order to disturb tissue planes for another time. And often I would clear the pelvis, the lower abdomen first of all. The advantage then is you get the patient out of trouble, they recover for the next 3 to 6 months. It lends itself if this is low-grade disease. Obviously very different if it's invasive disease because you don't have that time frame to wait. So for low-grade disease patients, then that is it. And then you can go back 6 months later to clear the upper abdomen. And a stage approach works very well. But you can't do a stage approach laparoscopically because the reason for the stage approach is you've got high volume disease, and that's a contraindication to minimally invasive approach. One question is whether to give HIPEC at both operations. There may be a benefit of that.
Thank you very much. And as minimally invasive surgeons, we always worried about the safety of peritoneal access. With you dealing with so much difficult peritoneal disease, how often do you have challenges in access, and whatever strategies for a safe access?
Yeah, I mean, it's about selecting the right. Often it's about selecting the right patients based on their, reviewing their previous surgery. It's good to look back, review the operation note. Often our cases are referred from other centres, so you need to get all the information you need. If the patient had an anastomotic leak or intradermal collection, that obviously would make you more concerned about the risk of adhesions. Again, the number of previous surgeries, were there adhesions noted at the previous operation? And then in terms of, and again, examining the patient is obviously important. You get a feel for the abdomen, heavily scarred abdomen on the outside, then I always worry about adhesions on the inside as well. So in terms of then access, similar, often using I prefer a cut down at Palmer's point in the left upper quadrant to get access if I was concerned about if the patient had a lower midline incision, and carefully counseling the patient to inform there's a higher risk of conversion to open. but Palmer's point is the safer. I used to use Ver's needle. I don't use it as much now. I just prefer a cut down.
Thank you very much. And how often you land up with, say, for instance, you mentioned about the anastomotic leak many times. Do you have challenges in missed injuries? Because many times these type of surgeries warrant pushing off the bowels to one side because you need more broader access to the entire peritoneal cavity. I'm sure you reposition the patient during operation so that the bowels does not keep coming on your way, because the idea is the completeness of exposure of the peritoneum. Do we have any special maneuvers of positioning the patient for doing this procedure? Because we get to see many times we change the angles, we change the right-left maneuvers. So what is your department's protocol on that?
So again, it goes back to careful selection of patients, and especially in a country that's got an obesity epidemic, I'd only select patients with normal low BMI, because in the patients with increased intra-abdominal adiposity, it can be impossible, despite the best techniques and the best will. You can't get the views you require, and it goes back to selecting the right patients with low-grade disease rather than invasive disease. Low-grade disease, worst case scenario, even if you were to miss a pocket of mucin, then you could easily go back. That patient may then develop a lesion on a scan in 18 months, 2 years time, and that can be very easily treatable. Whereas if you miss an invasive peritoneal implant, then you're in trouble. But going back to techniques of nothing more apart from then making sure you got a happy anaesthetist that's willing to put the patient in steep head down as necessary. But I think it all goes down to there's no particular, I don't use any particular special techniques to ensure the small bowels packed away or out of the way. It really goes down to the patient selection, to be honest.
Thank you very much. The other next important issue is a lot of the targeted therapies are coming up with big bang, telling they have better metastatic disease control. So how do you look upon those drugs? Are they going to challenge the HIPEC procedure in the near future, or how far the drugs are helping the patients as such?
Yeah, so certainly, and it's exciting times for medical oncologists and for the patients with metastatic disease. And you see some incredibly amazing complete responses or complete radiological responses to some of the immunotherapies. And I see that as cytoreductive surgery HIPEC does now, it complements, it's part of multimodal therapy for metastatic peritoneal disease. So it's not one or the other, but certainly in higher risk patients, those that are MSI high on the tumor biology would then have got better options now. But it's the two should complement each other, and maybe going forward that actually there'll be patients that were previously unresectable with conventional chemotherapies to downstage disease, that now the new and novel therapies will actually downstage disease enough to be resectable. And of course, there's some it's mainly lab-based research that's looking at potential new novel HIPEC agents, including immunotherapy HIPEC agents as well. So it's definitely the way forward, and looking forward to see how this area of surgery and on oncology goes.
Professor Wild, I think we momentarily lost your connection. Can you?
I can hear you now. Yeah. Yeah. Can you hear me now?
It's okay this side. It's okay this side.
I've just taken my video off in case you can hear me more clearly.
Okay, no, we are happy with the way things are looked upon, the right perspective, and I'm sure the good work being done will benefit a lot of patients. Maybe we look forward to have the opportunity to see one of your videos. Have you loaded your technique videos into your YouTube, Professor Boyle?
Yeah, certainly we need to do that. We need to be better at that. Certainly, we can. There is another that my colleague Mr. Sawaseka has. I know he's published a video on laparoscopic cytoreductive, a different video in colorectal disease. So that's available on the colorectal disease video library. But yeah, publishing videos of techniques is something that certainly looking to improve on.
Thank you very much, Professor Boyle. President, sir, your comments, and we'll call it a close. You're in mute mode, sir.
Really, we we listened and to the ends of surgery, Tan and Professor Jonathan, and we really enjoyed it, and it was an excellent work and demonstration, Professor Jonathan. And as far as Tan, the lecture is concerned, one has to enjoy the work, what he is doing. When it is affected, naturally the burning starts there. And the teamwork, leadership, and interpersonal relationship, and the organization, and the system, he has explained so well, and he stressed upon the importance of physical well-being, mental well-being, and emotional well-being. Above all, the spiritual well-being, in which India is specialized, and all these things are very important. And IAGES is grateful to these two great personalities who come and a lot of time and spend with us. And thank you very much.
Thank you, President. Madam Liana, are you with us?
I take this opportunity to welcome you all to Coimbatore once again for our National Congress IAGES, February 9, 10, 11. You're all my guests. Thank you.
Thank you, President. Madam Liana, are you with us?
Hello, yes, I'm still here.
Would you like to comment or would you like to give any questions from your side?
So obviously this discussion is a little bit above my training grade at the moment. But this is I just wanted to ask about HIPEC. It's just like, what are the common complications that us trainees should be aware about, of and manage them then post-operatively on the ward?
Professor Boyle.
Hello.
Professor Weil, Liana has a question regarding the post-operative complications. I would request, I think we lost Dr. Weil for a moment. Madam Liana, can you reframe your questions again for the benefit of the professor?
Yes, sorry, maybe my connection is a little bit poor. That's why I've switched my video off. So as I said that probably the separation is a little bit above my training grade at the moment. But I think as a trainee, what we're interested in is how to manage post-operative complications, and which of them are the commonest that we might come across on the ward post-operatively.
So this is following patients having cytoreductive surgery and HIPEC. Certainly in the UK, you're only going to be managing post-operative complications in patients having cytoreductive surgery and HIPEC if you work in 2 to 3 centres. The Christie in Manchester, Basingstoke on the south coast of England, and the team in Birmingham also do some. So it's a you're not going to come across these post-operative patients in practice and your training elsewhere in the UK because of our centralised specialist service. What you may come across is patients that are, because we operate on patients from all over the UK, that patients may be discharged from us and readmitted through accidents and emergency in the local hospital. So and often the management is no different than any other surgical patient in terms of the basics and a basic assessment, especially assessment for sepsis, which can be an issue. In terms of giving the HIPEC is very safe. It's got very low risk to it. The risks come through from the cytoreductive surgery and the morbidity from the cytoreductive surgery and HIPEC, but we're no different than any other colorectal or GI patients with and how we manage. We may try and manage anastomotic leaks more conservatively because of the difficulty, potentially hostile abdomen to go back into if they're beyond 10 days from a cytoreductive surgery and HIPEC. In the immediate post-op period, often the inflammatory markers are quite elevated anyway. So when compared to a standard colorectal procedure where the CRP can be a useful indicator for potential anastomotic leak, we don't bother with looking at inflammatory markers in our patients. We expect the white cell count to be elevated normally by day 5, and obviously we're relying heavily on CT scans to it's about like any other patient. To improve outcomes is detecting a problem, it's acting on it soon to minimize any risk and improve any outcomes if the patient was to suffer from a complication.
Okay. Thank you very much.
Thank you, Professor Weil. I hope if there are not more questions, and I request the honor of inviting Dr. Satish Midha, National Secretary, to propose the vote of thanks, please.
Good evening, all. So it was again a nice learning evening for all of us. So on behalf of IAGES Executive Committee, our President, I thank both our learned speakers, Professor Tan Aruparam and Professor Jonathan Wild. Though these two topics were on a different spectrum, but they were very useful topics, and it was a great learning experience for all of us, and it will generate new ideas, especially among the youngsters. And we know both the topics are important, and burnout is a common problem among physicians and surgeons. And we have to deal with it meticulously so that we can give the best outcome. And Dr. Jonathan, who has a focused area of working, we were impressed by your videos, especially. It was a good video presentations. So thank you again, both of you. Thanks, Professor Celia Silvaskar, for being with us this evening. Lina, to be a part of this meeting. So thank you all. Thanks our President, Dr. Thangavelu, and the convener of this meeting, Professor Kanagvel, and the whole DocFlexes team for arranging this IAGES prime time. Hope our association will strengthen in coming years and will have better meetings in days to come. Thank you once again. Have a good day. Bye. Good night.
Thank you, Secretary Sir. Friends, I am to inform the next program of the IAGES Prime Time is going to be on the 10th September. We have Professor Roxanne Liu from the Bates from California, speaking on various aspects of implementation of robotic surgery in various hernia repair. So we look forward to have a unique program and look forward to having you all amidst us. And with that, we come to the close of the session. Selva sir, are you with us? I think he's no more with us.
Yeah.
So thank you very much.
Thanks,
Sir.
Yeah.
Would you like to say something before we close?
I think I would like to thank both Tan and Johnny Wild for their excellent presentation and good discussion, and also Liana contributing from the ALS-GBI Training Academy. It's a fantastic organization. Thank you, Dr. Kanagwel, for bringing everything together, and Professor LPT and Satish Media for being the president and the secretary of the IAGES in coordinating the whole lot. We've got the ALS-GBI IAGES webinar next Sunday around the same time. So we will catch up then, and thank you very much.
Good night, friends. With the permission of the faculty, can we sign off the meeting?
Okay.
Thank you, Professor Weil.
Okay, bye.
Yes,
Good
thank
night.
you very much. Enjoyed it
Thank you,
thoroughly.
Professor.